Thanks very much for interviewing with us, Dr. Herbert. I know you're a family physician and a world-renowned researcher. How did you become interested in research?
Well, I had been interested in research from the time I was a medical student. I had done biochemistry, so I'd worked in a lab and done bench research before I went to medicine. Decided that although I loved it and my professor would have liked me to have done a PhD, I really wanted to work with people. So I went into medicine, but I did a project when I didn't have to as an undergraduate. They had just abolished the MD thesis, which we're now bringing back in, and I did a project on LSD users in Vancouver. So that was one of my early projects.
Wow.
I was too chicken to be a user, so I could study it, right? So,
Great.
But what's instructive is that when I went into practice, not dissimilarly, the questions that interested me were practical questions about what was going on around me. And all of my projects in the early years particularly came from research questions. The research questions that I was interested in, all of the research questions I was interested in were derived from practice. My own practice or questions that came up in the group within which I was working. I can't imagine not asking questions about what we do.
Mm-hmm.
But there was no technology for studying practice-based research in the 1970s. There really was, there were few supports. Right. I was lucky enough to find my way to NAPCRAG, which became my home for research, where I derived my research skills, really.
Okay. What were some of the questions that occurred to you from practice?
Well, an early area of interest for me was I worked in a setting with a lot of social problems and working poor and people who were multi-generational welfare and so on. And one of the areas that I became interested in because I saw so many people suffering was the whole kind of area of family violence and in the emerging issues around child sexual abuse. And we observed some things in practice. We actually reported in one of our early publications was a letter to the editor of the CMAJ reporting on what we observed around gonorrhea in children, which in those days we were taught was something that kids got from the bed sheets. And I mean, it's not that long ago that we believed that. And we reported the finding of child sexual abuse in a family, and that was actually my first publication in an area where I actually subsequently did a lot of other work. But early projects included, again, early projects included things like a study of the surgery for a morbid obesity. There were a lot of surgeons doing procedures, and there wasn't a whole lot of metabolic understanding, and there was nothing about management of these patients post-surgery. And they would come into the community practice, you know. And so I had a patient. I didn't know what to do with the patient, so I wrote about it. I went and did some research, and in the literature in this case, and wrote a review, and that was an early paper. And as I talk about it, I can see the face, of course, of the patient that gave rise to the research question. Early work was really descriptive. We described the youth clinic where I worked and the epidemiology of the kind of illness that we were seeing, and some early comparative work on patient understanding of expectations, for example, of psychosocial intervention. What did patients need versus what they wanted? And you know, try to make that differentiation, things like that. But all of the diversity of questions had in common that they came from issues that arose in practice that I couldn't find the answers to in elsewhere. There wasn't literature around it. And it didn't occur to me that I couldn't answer those questions, which when I look back on it, is kind of funny because I didn't have a formal postgraduate training in research. And I was a busy practitioner, but I was lucky enough to be working in a setting where the group supported the kinds of things that I was doing, and it just mattered. And I wrote at night, and I wrote on weekends, and I wrote after I fed my baby, and those kinds of things, and then gradually increased my skills over time. I've talked about bootstrapping. A lot of us who started in those days as physician researchers didn't have formal training in epidemiology, for example, but we learned what we needed to learn. And as family doctors, I think we're well prepared to do that because there were lots of areas in clinical practice where, frankly, I didn't know what to do or how to do it, or didn't have a particular skill. And if I needed to, I'd go out and learn it.
Right.
So this was one more example. And I was never mystified by research. I didn't see it as something mysterious or beyond my reach. Right? And I've always felt that that was really important for our learners, that to see it as simply another set of skills in another domain of practice, that asking questions and becoming engaged in finding answers, whether it was by doing small-scale work in your practice or working to give patients up to a larger study, or to apply for funds and hold grants and so on. It's not beyond reach.
Good. I know that another area of your work involved participatory research.
Yes.
That was a big area for you. Can you tell us about that?
So the place where I worked, you have to understand the setting, the timing. So I started practice in the early 70s. I mean, I was a child of the 60s, if you will. So sharing power and breaking down some of the hierarchies, social hierarchies and so on, was something very important to me. In fact, Howard Bergman and I love to remember that we first met when we were involved with the student governance of the day, it was CAMSI, preceded whatever the student organization is called now, I can't remember. And we were involved in trying to develop essentially social change in terms of medical practice in those days. And so the idea of power sharing was always very important to me. It remains important to me, that whole sort of notion of breaking down the barriers, breaking down the silos, not differentiating between patients and doctors like that, but trying to keep it on a level plane. And so when I began to work with research in communities, in particular larger projects, the idea of developing questions in collaboration with the community was something that seemed very natural to do. I didn't know that there was a field at that time. When I first started to do work with the women's community, for example, and communities living in poverty, I really didn't know the language that described what I was doing. And it was only as we began to work and we started to look at the literature that we discovered some of the early descriptions of what we call participatory research. And there's a number of ways of describing that particular concept. And then I got really passionate about it, and I had a sabbatical after my term as department chair, and actually did systematic work in the area and began to write about the community empowerment work we were doing in that way, and became, I suppose, an expert in terms of the literature and began to apply it then to primary care specifically, and to family medicine research. And there were a number of people who were pioneers in this within Canadian family practice and the U.S. That over the late 80s, early 90s, really popularized the concept as being important. And the notion here is that when you do research and you're working with communities, you need to share power at all levels, from the development of the question through to the ownership of the results. And that research is not of and by itself sufficient. It is necessary but not sufficient to be doing research, but it's for education for the purpose of affecting change. And so it's a triangular kind of relationship. And so working with communities, for example, where there's particularly where there's a differential of power, and you can argue there's always a differential of power between researchers and the researched, but working with communities living in poverty, First Nations communities and the like, it's particularly important that the researcher from the academy is clear on what will be the benefits for the community and how do we frame that research so that it's meaningful for the community. An example, when we were doing our work in Haida Gwaii in the Charlottes, which was a major project that I became involved with, we developed that in such a way that some of the technology that we're using, focus groups, for example,
Okay.
that was a technology that we made sure was learned by our colleagues who were working in the community. And they went on then to be able to use that technology after the project. I mean, it may not sound very high tech, but it was pretty important to people who didn't have that skill before. In turn, we learned skills. I have a great story about skill sharing. When we were doing the work in Haida Gwaii, and we were preparing the feast at the beginning of the project, because to be culturally sensitive, we knew we had to have engagement strategies with the community, and that's what you did. And so okay. The docs and the academic researchers and the docs in the community prepared the feast for the community members and then served it. And we were working with our community health representatives in the Aboriginal community. And one of my colleagues, a community health worker, at one point when I said, what can I do? She said, you can go out and you can get me some Labrador tea. And I said, well, I will, but I don't know what it looks like. And she said, she said, let me go with you. She took me outside. She pulled these branches off and she said, I suppose you don't know how to strip them either, do you? And I said, no. And she said, here, I'll show you. Showed me. And she said, now you have a skill that's going to be useful to you, you see. And in fact, it was that kind of exchange of knowledge and skills that really hooked me on this notion of power sharing, that we brought different things to the table, and we truly worked in a mutually respectful and trusting way. We developed, I think, some really useful ideas around codes of conduct of research with communities, which Anne Macaulay went on to develop much more deeply in her work with the Ganawagi community.
Right.
But it was philosophically consistent with the way in which I approach practice, and it felt much more appropriate than some of what I had learned, of course, over time, was the conventional approach to research. Why do you do participatory research? Because if you don't, you can't answer the kinds of questions I was interested in. It's hard, it's time-consuming, it takes much longer than, an imposed trial or whatever. And if you don't need to do it, I suppose you wouldn't necessarily advise that to people. But if you're going to do community-based work, you need to truly engage with community. Otherwise, you get your perception of truth, but it's not even an approximation. Evidence, some of the things we know now about Margaret Mead's work, when she went into the South Pacific, and, we learned much later that she was told the things that people thought she wanted to know.
Mm-hmm.
I didn't want to do that kind of research.
Right.
So
it's a bit of the person or the patient's perspective that helps drive the research.
So it's very much about the community's perspective, the patient's perspective, the subgroup's perspective. A project that I did, one of my graduate students did, and I participated in as her supervisor and colleague on that project, was published in an article called Welfare Bums or Welfare Mums, and the longer title, and that comes from a quote, where we were looking at a group of women living in poverty and trying to understand their experience of health and illness. And, if we'd gone in and done a traditional survey or something,
Right.
we would have, we would have collected data that very much self-fulfilled our prophecies.
Right.
Well, because we would have had to have sort of thought about what our coding was before we started. So we used qualitative approach, but we used we used qualitative methods, but we used a participatory approach. We came in appropriately humble and said, how can we work with you so that we can understand this phenomenon and also help you to move along your agenda for this particular group of people? And that was a really important project. It collected, I think, some good data. We learned a lot. But it would have been very different had we approached it differently. Right. So, in some ways you can say it's not right or wrong, it's different, but I actually think you can make a judgment call around community-based research that there are some areas, particularly when you're dealing with again, communities with real power differential, communities that have been disempowered structurally over time, and where there's danger for the community in some of the research questions that might be addressed.
Right.
That you have to approach those in a much more participatory way. So, for example, there are questions that in our First Nations communities, in Native American communities, there are questions that the community is not interested in going into a research engagement around because of the concern that what is discovered, if it's done in a more conventional approach, may be used against them.
Oh, I see.
And they're not wrong. They have history that justifies that belief. It's not paranoia, it's real. And in fact, it's in some of the ethnic communities around the world, particularly in the Aboriginal communities, that the best work has been done in terms of developing codes of conduct, ethical approaches that are much more sophisticated than they used to be. And they're all in this kind of space, this general space that you can describe as research partnership, but truly partnership. When we talk about partnership or collaboration, often people mean co-optation or really not true balanced partnership.
Right.
So again, it's consistent with what I believe actually about practice. I only know one way of working. I'm not smart enough to be one person over here and a different person over here. And I feel that just as we are trying to teach with the patient-centered clinical model, the notion that we participate with patients in their health care. In the same way, we are working with people if we're doing people-centered research, community-centered research. They're not objects.
Right. Right.
Well, the primary challenge of a participatory approach is time. It takes a long time to develop a relationship with a community or a group with whom you're going to work. Much as you could say, it takes a long time to develop a relationship with patients wherein they will tell you the full story.
Right.
You learn little bits, but you don't know everything until people trust you, and not different. So time is difficult for the participatory researcher. The other difficulty that I think is really prominent is that truly the relationship is key. And so if you want to have students involved, for example, junior colleagues that come in to do a project, it's important that they be introduced on your credibility. Again, not too different than having a student in your practice, you might say. But a graduate student can't just come into a community and do a piece and then, leave.
Right.
Because notion of participatory research requires that you are there for the duration of the exchange of information. Knowledge transfer, the new language of integrated knowledge transfer that we all are on about now through CIHR, integrated knowledge transfer has its roots in participatory research.
Right.
It's about that same sort of thing. The idea that we don't own the knowledge. We may uncover information, derive knowledge because of the analysis we do in context, which means in partnership, but then we got to return it to the community. So that's a barrier for some people because they say, well, I didn't sign on for that. I want to do the research. I didn't sign on to have to come back and, give back talks to the community. I'll publish my papers. And besides, I'm the objective finder of truth.
Uh-huh.
I don't want to be engaged with the community because then I'm going to be subjective. Well, so there's a philosophical barrier for some people to doing participatory research. If you actually believe that there is in human relations such a thing as an objective truth, then it would be very difficult for you to engage in participatory research. I would argue it will be very difficult for you to do knowledge development with communities or groups within our society if you don't understand that there is a subjective quality to all of this. We all have our standpoint, and that the important thing is that you identify and try and reflect on where you stand, your biases, and how you are interpreting the data, and you constantly cross-checking it.
Right.
We have the same concerns raised, about qualitative research generally.
Right.
You will hear people say, well, how can you do qualitative research? Because that's so subjective and, it's your interpretation. Well, there's a lot of interpretation that comes into even deciding what research questions should be asked. I suppose you can argue that when I used to run columns and study protein chemistry, that was objective research. That was probably the last time I did truly objective research.
Right. So I've heard you talk about the relationship and the significance of the patient's story or the research subject's story. Yeah. And qualitative research. I have to ask this question: what's the relationship between stories and family medicine research, family care?
One of the things that drew me to qualitative approaches to research, qualitative methods, and to developing my own skills in qualitative design and analysis was that I learned in my experience as a family doctor that I only truly understood my patients when I listened to their stories. And that listening to their stories gave me a richness of understanding that I didn't get if I had them fill in a checklist or a questionnaire. I use those as tools in my practice, but pretty early on I realized that I could use things like questionnaires as a trigger. Give you an example. I used to use a questionnaire in my youth clinic that included a question about sex, information on sex. So these were mostly teenagers coming to the clinic, and we would ask a question on the questionnaire that said, do you have any questions for your doctor about sex? Mm-hmm. No one ever said yes on the questionnaire. But the message was, if you have a question, this is a place you can ask it. And we were convinced that by introducing the subject in that way, leaving pamphlets around the office and so on, it opened the door then to ask a question for the patient, to ask a question they might not have felt safe to ask. In the same way, I think that I learned that you don't necessarily get answers in a first exchange. And so I was really drawn to the idea of iterative development of knowledge, which we do in qualitative design, and the idea of interviewing until saturation, till you're starting to get repeats of the information that you're the phenomenon you're trying to understand. information about that phenomenon. And so much of what people understand about their own experience is actually best described as a story, as a narrative. So, again, it takes time. It's a longer answer, but than a one word, a short answer question. The essay takes longer than the short answer question, but multiple choice isn't a good way of learning about the human condition. And I am interested in the complexity of the human condition. So patient stories help me to understand that in the clinic, if I'm dealing with my patients. In the same way, if I'm trying to understand the experience of a Native community with diabetes, of an individual or a family with their diabetes, then letting myself be quiet and hear the description of how diabetes came to be in Native communities, which leads to people talking about residential schools where they learned to eat the kind of food that has had certainly a major role to play in the development of the illness. These are all really important elements of understanding experience. So qualitative approaches are about hearing the words. Stories may be short, but it's the words of the person, and then trying to really understand what those words mean. I heard a man last week who's a patient living with HIV, we were at a meeting on chronic illness, and he was asked to talk about chronic illness. What do patients want, right? Well, you might have some ideas in your mind of how he might have answered that question, sorts of issues that come up for patients. This man had really 2 points to make. He said, there are lots of medical things that you'd recognize, but they're mostly dealt with pretty well. One way or another, they get dealt with pretty well. He said, my main problem is loneliness. He said, I am desperately lonely sometimes with my illness. And he went on to talk about that. You could have heard a pin drop in the room. If we'd given him a checklist of what we thought were the needs of HIV, of patients with HIV, we wouldn't have heard about loneliness.
Right. Right.
The other thing he wanted was choice. He said that, we organize our systems, but it's very important for patients that they have choice. That he said, you're not all the same. The doctor who's on in the clinic on Monday isn't necessarily the doctor I want to see. So I want to know that I have choice. It was really very powerful and reminded me again of how my assumptions about what patients want, my assumptions about what might be the explanatory model for whatever condition I'm interested in, may not actually be the salient points. And if I don't elicit the story, then I'm not going to know.
Right. So I understand that you've not only done your own research, but you've spent a lot of your time advocating for research through through speeches, presentations, and through the education system.
So
tell me a bit about that.
Probably if there was a one word that some of my friends would use to describe me, it would be passionate. I'm passionate about a number of things. One of the things I'm really passionate about is the idea of empowering others to ask questions, to do research in the small R research, to be scholarly in their approach to knowledge development, to be believers that they have the ability to ask a good question and to identify when the answers that are available are not germane to the real question that they have. And so I've spent a lot of time with young faculty, with students. In fact, I'm a sucker for a student or a resident who, to this day, I am a sucker for a student or a resident who has a research question. If they contact me by email or by telephone, I'm in. I don't think I've ever refused a student because I think that I don't know which of the students or residents or young faculty with whom I spend a few minutes or some of my time, I don't know which of them are going to be hooked. But some of them are going to get hooked. And some of them are going to do something really meaningful. And the most exciting things that I have done in my whole career have been evidenced by the people with whom I'm working, whether it's a patient or a learner, stretching beyond what I could imagine. So the patient who makes a life change,
Right.
because I've actually hung in with them and I've been able to watch it, and sometimes will say to me, you know, it was what you said or what you did that really made it possible for me. They made the change, but I could act as a catalyst. In the same way, when I work with learners or young faculty, I guess I'd like to believe that some of my enthusiasm, a little bit of what I do know, some of my experience, will rub off, will help them to do their own work. And I've been really excited by some of my former mentees or trainees who are at this meeting, you know, who are publishing the literature, who are leading now themselves, and paying it forward, right? So pretty exciting.
Good.
Yeah.
How do we make, one of the problems that family medicine research has had over the years is getting funding, getting recognition. Of course, the bench research, when you say you work in research, everybody thinks you work in a lab. So how does this profession move itself forward in terms of funding, recognition, and application?
So I'm old enough to remember when we had no money to do research, and likely no possibility of getting any money in the current structures of the day. And so we would cobble together our projects. We often spent money out of our own pockets to do our research projects, and certainly as a practitioner, when that was the case. Small R research doesn't take a lot of money. If you're doing, for example, the kinds of descriptive things that Ian McWhinney encouraged all of us to do, be disciplined describers of the work we do, it doesn't cost you a lot of money. It takes you a bit of time, but, you know, it's not expensive. So in the early days, we didn't have money. And then we got empowered enough to believe we could apply for money. And then we began to realize that unless we became engaged in the funding committees and in the organizations that actually developed the criteria to give the money, that our people were not likely to be so successful. And so some of us who were now recognized as doing reasonable work realized it was our responsibility to get on those committees, and so we started to do that. And we were able to shift the curve around what kinds of research methodologies were acceptable and so on. And at the same time, we also worked really hard to make sure that our research community was better trained. And that meant both formal and informal training. So initially it was informal training for a lot of people, workshops and meetings and the like, short courses. Increasingly, in the last number of years, we've believed that we need to ensure that our trainees have masters at least, and increasingly PhD preparation, so that they're going to be able to compete in a level playing field and be successful. And we're seeing the fruits of that labor. So there is a caveat, though. So one of my concerns is that as we regularize, if you will, research, as we become part of the research community and no longer have the experience of people's eyes glazing over when you say you do family practice research, we run the risk of our research community being co-opted and not developing our own research agenda, but looking to do whatever happens to be the fundable question of the day. And this is a real issue. The other thing is that we run the risk of becoming so competitive for the funding opportunities that we'll lose the power of the collaborations that have been the heart of the kinds of research development that has occurred in our field, that has been able to address some of the really important clinical questions in practice, where you needed large numbers, and you could only do that by joining together.
Right.
So I'm not worried right now. I think we have great research collaboratives going on. But as we move along the path, we will have young researchers who are going to look selectively at what they get engaged in. And in the academy, you will develop, you will progress most rapidly along the career path if you are the PI, if you do solo or lead author publications, if you work on the sexy problems, the problems where you can get funding, and so on. And again, Ian McWhinney cautioned us a number of years ago at an section of teachers meeting, actually. I remember him speaking. And Ian got up at a section meeting and he said, I'm worried that, I'm paraphrasing, but I'm worried that as we are more accepted now as a mainstream discipline, and in fact we were in those days looking at the development of the default pathway to practice, where you had to do family practice training or you could no longer enter practice, required residency. And his concern was that we would dilute the kind of philosophical stance we were coming from. And I would make the analogy that with research that, well, in fact, he talked at that same meeting, he talked about the risk that our research agendas were being co-opted by the establishment of the day, so that, for example, questions about the longitudinal natural history of illness, which only we could answer, were not fundable research questions, because you could only get maximum 3 years funding, maybe 5 years. You weren't, in those days, certainly, no one got 10 years of funding to be able to follow something over time. And, to study a 6-week trial or 13-week trial of an intervention has been very traditional in the literature.
Right.
But who cares whether something worked for 6 weeks or not?
Mm-hmm.
What we're interested in is whether something actually makes a difference over time. And that's the kind of question that we can answer in practice that nobody else can address in primary care. We have that power. But then we need to make sure that our researchers don't turn away from that kind of difficult research or difficult to fund research to do the easy stuff that'll be career development quick, that will mean that their career trajectory will be much more rapid than if they did the more difficult research. So it's some kind of blend there. I think that we need to make sure that our trainees succeed. And so I certainly encourage people, for example, not to do participatory research when they're in their early development of career path. I engage them later on because it takes a long time to get your results. On the other hand, I want to make sure that they aren't doing, well, what would be the family practice equivalent of a drug trial, right? Really fast research that compares two drugs, gets lots of publications, right? But who cares? Yeah. I don't want to see family practice doing who cares research. I want to see that we're doing meaningful research. And we need to keep we need to make sure that we're reflecting on our intentions, reflecting on our agenda and on our outcomes, so that we don't lose the power of our discipline.
What will be the challenges, the challenging questions that you want to see studied in the next decade or two?
Well, a question that my university asked in the last few weeks was, what's the answer to the question in your discipline that we need to find? What do we need to find the answer to in your discipline over the next 40 years? And I thought to myself, gosh, I don't think I have the patience to wait 40 years for some of those questions in primary care and family practice. I've been waiting 40 years for some of them to get answered, or at least get implemented where we have the answers. I think that some years ago I gave a keynote at NAPCRAG, and I talked about the importance of family medicine researchers getting involved in health services research, really looking at models of practice, models of care, and how do we provide better care in the broadest possible sense for the population. How do we address needs? And we're seeing some of that now, and I think that we, in this next few years, have a real opportunity to evaluate the new models of service delivery, be it the medical home in terms of the kind of model we're talking about in the college, or more broadly, again, the idea of how are we going to care for chronic illnesses? What kinds of models will evolve? We need to be working on that kind of research. It's not instead of the more close to the ground patient-physician kinds of questions, but it's certainly really important research, and we need to make sure we're in that space. Others otherwise will begin to try and answer those kinds of research questions, and they won't have that same informed position that we have. So that's one area. Another reality is that many of the questions that are important in terms of patient care require an interprofessional, a multi-professional project team.
Okay.
Family doctors need to be involved, family medicine researchers from all of our professional persuasions need to be involved in some of the large-scale projects, big science projects. If you look at personalized medicine, which, as I think some of us have said, we all thought we did personalized medicine until genomics kind of claimed that was what they were going to call their space. But as we look at the development of personalized medicine, which is a language of today, it's very important that family doctors be involved in examining genomics, the meaning of genomics. Some of the particularity research now that would look to see how can we define the special populations for whom particular kinds of therapies can be targeted. You need to have family docs involved in that kind of research too.
Okay.
And so I think there are a number of areas where, again, there's some where we will lead and there's some where we will collaborate, but I think that it's very important that they be the questions that are really relevant to how do we deliver care, because that's our space, that's our domain.
Right.
Our domain is patient service, patient care. So that's one area.
Okay.
The other big area is still the kinds of research that Ian McWhinney presaged when he did his early writings about patient-doctor relationship. It's not that we're the only ones that are interested in the patient-doctor relationship, but I think some of the best work has come from family medicine. Obviously, I have a bias. I'm at the Center for Studies, the home of some of the best work around patient-physician relationship, patient-healthcare professional relationship. I think it's very important we continue to work in that space too, and to continue to explore that model, to understand more about the nuances of that model, because I think that we don't know it all. We have some understandings, but we need to be developing theory. We have to be developing models and then testing those models. So it's not all about doing, it's also about reflecting and thinking and developing conceptual models. Well, I want to say one other thing about how we engage our learners in research.
Okay, good.
A long time ago, when we still had the National Research Committee in the college, and I had, as a community-based practitioner, that was one of my first involvements with the college. I was appointed as the community-based representative to the National Research Committee. Within about 6 months, as it happens, I became, of course, a member of the academic department and moved my practice to to the university, which is historically often what has gone on. But on the National Research Committee, and this was in the 1980s, we thought a lot about how should docs be involved in research and how should we engage our students in learning a research attitude, a positive research attitude. Mm-hmm. And we determined then something which is still true today, and that is that we thought that all doctors needed to be prepared to ask a question, to be able to reflect critically on what's known and decide what isn't known, and to be able to generate a good research question. And be willing to contribute the questions that arise from practice so that research would be meaningful, more meaningful perhaps than it had been up till then. We thought that a subset would become more engaged in research, and we might turn them on to research mm-hmm. in one way or another, and they might then become participant in projects, hopefully provide patients for larger trials, or become collaborators on research and perhaps more enhanced way from simply being part of directing the questions. And then there'd be a subset, a smaller subset, who would become career researchers. And in those days, we thought that the most we could imagine was maybe 50% time. We actually thought more like 2 days a week. You know, we really didn't think about clinician scientists in family medicine research, which would be the fourth tier now, mm-hmm. we would say. I don't think that's changed. I think that we still aspire to, or should aspire to, our trainees all coming out with the skills of critical appraisal, analysis, reflection, and the ability to ask a question, and see themselves as responsible for developing good questions. That it's intellectually stimulating to do that. And it still troubles me that when we do surveys that a lot of people tell us that they go to family medicine for their residency because they don't have to do research there. It's not going to be a requirement. I think that's a shame. I think we need to change that. If we can, a cultural shift over time. I don't know the best way of doing it. We invented in the 1980s the idea of the resident project. Mm-hmm. We knew even then that the R word scared some people off, and we actually didn't call it the resident research project. We called it a resident project, and identified that for some it might take the shape of a creative project, could be an arts project, but it had to do with reflection, critical appraisal, and all those things. And I think we need to re-examine with our residents how best to develop positive research attitudes, because mm-hmm. I think there's become a bit of the resident projects in some settings at least have become a bit mechanistic. It's kind of a hoop to get through. Mm-hmm. And I know that many residents sort of view it as, eye roll in first year, and then, moments of panic in second year when they have to come up with a question and kind of do it. And so then you get some pretty crummy work that comes out of that. Right. We still get the, occasional person who's turned on and becomes brilliant, turns out to really be bitten by the bug. So I would still argue that something that involves hands-on is important. Because, again, I'm satisfied that if we get 1%, 5% of residents across the country over 10 years is a big cadre of new researchers. So, it's worth the investment of time. But there may be better ways than we've got currently to help turn residents on to this positive research attitude. That's the critical piece for me. Mm-hmm. It's the idea that I'm smart enough as a family doctor to ask questions that are meaningful, to carry out research that could get answers. And I have the opportunity and the responsibility to do that kind of work, just as I have other kinds of opportunity and responsibility in my practice. That's an objective that I think has to be an objective of the college. Mm-hmm.
Thank you very much, Dr. Herbert, for speaking with us. It's very enlightening. I enjoyed it. Thank you.